Assalamualaikum and good evening to everyone and Sir Eddie. My name is Rafi and Daud, and today I'll be presenting to you on my Fundamental Medicine Assignment 1 on the topic that I choose, Chronic Obstructive Pulmonary Disease, COPD. So this is the content of the flow of my presentation. First will be the definition of COPD, second, etiology, third, clinical manifestation, fourth, investigation, fifth, differential diagnosis, sixth, treatment management, seven, complication, and lastly, prognosis. So starting with the definition of COPD, what is COPD? COPD stands for chronic obstructive pulmonary disease, which is a chronic inflammatory lung disease that causes obstruction or narrowing of the airflow from the lungs. And COPD refers to two things, chronic bronchitis and emphysema. Next is the statistical report from the World Health Organization. So, did you know that around 384 million people, especially adults, are diagnosed with COPD, and around 3 million people die each year due to COPD. COPD is the third leading cause of death globally, followed by cancer in the second place, and first place is obviously the heart disease. Women are 2 times more likely to develop COPD than men. Why? Because women have smaller airways compared to men. So when it is smaller, it is more narrow, so it has more effect when they smoke, and it causes more damage to the airways. Around 20% of smokers will develop COPD during their lifetime. Moving on to etiology. So smoking is the number 1 cause of COPD. Why? Because the harmful chemicals in the smoke causes the damage in the lining of the lungs and airways. Second is occupational exposure, which is basically an exposure in the workplace, such as dust from gold mining, dust from coal mining, and fumes from welding. Third is genetics. Alpha-1 antitrypsin is the protein that helps to protect the lungs, and it helps to break down mucus. So when alpha-1 antitrypsin is not present or is deficient, it will not be able to remove the mucus and can cause the blockage of the airways. And next is the pathophysiology of COPD. As I mentioned earlier, tobacco smoke or smoking in general causes the risk of COPD, and it is the number 1 risk of COPD, followed by air pollution and alpha-1 antitrypsin deficiency. So, for example, when a person smokes, it will cause continual bronchial irritation and inflammation in the lungs. So when this happens, it will cause chronic bronchitis. Chronic bronchitis characteristic is bronchial edema, basically the swelling of the bronchus, and hypersecretion of mucus, as well as chronic cough. However, the person may also experience breakdown of elastin in the connective tissue of the lungs, which will lead to emphysema. Emphysema is basically a destruction of the alveolar septa, or the rupture of the alveoli, which causes the airway instability. I'll explain on the instability on the next slide. So when these two occurs, bronchitis and emphysema, it will cause airway obstruction. As mentioned in the title, it is a chronic obstructive pulmonary disease, and it will cause air trapping as well as dyspnea, basically another term for breathlessness or shortness of breath. So when these two is not treated properly or prolonged, it will cause hypoxemia, basically it is a low oxygen level in the blood, and it can cause hypoventilation, which is a low level of oxygen in the blood as well, where the body doesn't meet the demand. And lastly, it will cause cor pulmonale. Basically, it is a right-sided heart failure where the heart has to pump a lot of blood to the lungs, and it will cause a right heart-sided failure. I'll explain that further on the complication. And moving on, still in the pathophysiology, I'll be comparing between healthy lungs and COPD lung. So in normal bronchus, as you guys can see in the image here, it has no swelling or inflammation, and normal bronchus function is to carry oxygen to the alveoli. However, in this image, it is bronchitis. As you guys can see, it is an inflammation of the swelling and narrowing of the airways, and there is an excess mucus that could block up the airway. So bronchitis characteristic is the inflammation and the excess of mucus. Next is the normal alveoli. As you can see here, the function of alveoli is obviously for gas exchange to occur. And the important component in alveoli is called the elastin fiber. Elastin fiber has to recoil during inhalation and exhalation of gas exchange. So in emphysema patient, the alveolar membrane is breakdown. So it causes smaller and fewer air sacs, as well as the elasticity of the air sacs loses because of the breakdown of elastin fiber as well. So when this happens, it will makes gas exchange more difficult and causing difficulty in breathing as well. Moving on to the clinical manifestation, there are 8 clinical manifestations that I've gathered. First is shortness of breath, wheezing, chest tightness, chronic cough, lack of energy, weight loss, production of mucus, and trouble of sleeping. Next is the investigations. So how to investigate whether a person has COPD or not. So first is using a spirometry, which is a lung function test. So by blowing into a large tube connected into a small machine, it can measure how much air your lung can hold and how fast can your lung blow out the air. However, a medication has to be used before performing this procedure, and the medication is called post-bronchodilators. So by using the bronchodilator, it helps to relax the airways and makes the procedure much more reliable. So if it's less than 0.7 T, it will confirm airflow limitation. Next is chest X-ray. Chest X-rays help to rule out between pneumonia and emphysema in a patient. And lastly is the laboratory test. As I mentioned earlier, the alpha-1 antitrypsin is one of the factors that can cause COPD. So by doing laboratory tests, it can help to identify whether the person has genetic disorder of alpha-1 antitrypsin in their body, which may cause COPD. Next is the differential diagnosis, and I've put a quote here: not all smokers have COPD, and not everyone with COPD is a smoker. So a good example to differentiate the diagnosis is between COPD and asthma. So first is the clinical feature, which is age. Usually people with COPD are much more older in their age, usually more than 40 years old, whereas asthma is much more younger, which is less than 30 years old. The family history for COPD is very uncommon, whereas family history in asthma is common, so it goes by generation to generation. Smoking in COPD is nearly all, so people who smoke tends to have COPD, and smoking in asthma is possible, so people who smoke has the possibility of asthma as well. Sputum production or mucus production is very common in COPD, as mentioned earlier. The excess of mucus build up in the bronchus, and sputum production in asthma is uncommon. Lastly, the airflow limitation in COPD patient is irreversible, meaning that it cannot be fixed. It is destroyed. As I mentioned earlier, the alveolar septa breaks down, which basically destroyed its overall structure and its elasticity. It cannot be repaired. And whereas for asthma, the airflow limitation is reversible. It's reversible, so it can be fixed back using the medication such as bronchodilator. Next is the treatment management. So there are three things that I have divided into: prevention, medication, and surgery. So for prevention management, first is quit smoking. By quitting smoking, it helps to reduce the further damage or the further cause of COPD, and it helps to reduce the coughing as well as bring down inflammation. Next is by getting vaccinated. Getting vaccinated against pneumonia, influenza, and coronavirus help to reduce the illness that can cause death in COPD patients. Next is the medications. There are three medications: bronchodilators, inhaled corticosteroids, and antibiotics. So for bronchodilators, as I mentioned a lot earlier, it helps to relax the muscle and helps to relax the muscle around the airway to make breathing much more easier. Next is inhaled corticosteroid. It helps to decrease the exacerbation or the worsening rate of COPD and helps to improve to the response of bronchodilators. Next is the antibiotics such as azithromycin, 250 mg per day. It helps to reduce the worsening rate of COPD as well. Moving on to surgery. There are two types of surgery: lung reduction surgery, lung volume reduction surgery, and lung transplant. In lung volume reduction surgery, it helps to improve the overall survival rate in emphysema patient. And in lung transplant, it helps to improve the overall quality life of the patient, and it helps to improve the functional lung capacity. Moving on to complications, there are four things that could cause the complications from COPD. First is respiratory infection. So people with COPD can cause respiratory infection because they are more likely to catch cold, flu, and pneumonia. Why? Because people in COPD have the difficulty to clear out or to breathe out the bacteria, dust, and air pollutants in their lung. So it causes them more at risk at developing infections in their lungs. Next is heart problems. As I mentioned earlier, one of the cause of prolonged COPD is cor pulmonale. So cor pulmonale is one of the heart problems which causes right-sided heart failure due to pulmonary hypertension, where the right ventricle pumps in high pressure to the lungs to give more oxygen due to the lack of oxygen from COPD. Next is lung cancer. People with COPD can have lung cancer because of the inflammation, the damage that is caused by COPD in the bronchus or the alveoli. It makes the cell to replicate more, and it has the possibility of the cell becoming mutate and turn into cancer. Now, lastly is depression. Why depression can cause complication? You may be wondering. Because depression occur due to their daily activity being stopped, since they have difficulty in breathing, breathlessness, dyspnea, and chronic cough. This will cause depression because they can no longer do their morning jogs, their morning walks with their family, so they can only stay at home, which can cause depression. Moving on to the last part, the prognosis. So the classification of airflow limitation severity in COPD based on post-bronchodilators FEV1. So in stage 1, which is the mild case COPD, the normal lung function is greater or equal to 80%, which means that their airflow limitation is mild, low, and chronic cough and production of mucus is possible in this case. Stage 2 is moderate COPD, and the normal lung function is between 50% to 80%. There is a greater airflow limitation in stage 2, and there is worsening of the shortness of breath and fatigue. There is also limitation on daily activities, and it could impact the quality of life. Next is the stage 3, which is the severe COPD. The normal lung function of severe COPD is between 30 to 50%, which will obviously cause an increase in airflow limitation. And this will cause more shortness of breath, chronic cough, and mucus production is confirmed. The last stage, which is stage 4, the very severe COPD, the normal lung function is less than 30%. This is very severe reduction in airflow that could affect the heart, as I mentioned earlier, the cor pulmonale, and it could also affect the circulation system. And people with very severe COPD in stage 4 tends to be hospitalized, and they may need oxygen therapies to help them feel better or to treat stage 4. And that is all for me. This is the reference of my studies. Thank you.